All right, guys, welcome back to Underground Science. And in this video, we're going to be talking about familial amyloid cardiomyopathy. All right, so let's go and get started. Okay, so first, we should know that if we compare this to senile cardiac amyloidosis, right? In senile cardiac amyloidosis, we had non-mutated transthyretin, right? That over time, with age, misfolded and then deposited in your heart tissue, causing it was often asymptomatic but could lead to mild restrictive cardiomyopathy. But familial amyloid cardiomyopathy, instead of the transthyretin protein, or instead of the transthyretin gene being non-mutated, we actually have a mutation in the transthyretin gene. Okay, so this is actually, first of all, it's autosomal dominant. Okay, so you only need one copy from your parents in order to get this, right? So it's autosomal dominant, and it's actually a mutation in your transthyretin gene. Mutation in transthyretin gene, okay? Also the TTR gene. And so this will eventually lead to amyloid deposition in the heart, leading to restrictive cardiomyopathy. Okay, so that's important. And as we know, so if we talk about this more, so mutated, so it's going to be a mutated transthyretin protein, mutated transthyretin that will actually deposit or misfold. First, it's going to misfold, right? And as we know, amyloid is misfolded proteins. It's going to so this mutated transthyretin protein will misfold and deposit as amyloid. Okay, then it'll deposit as amyloid, which is misfolded protein. Where will it deposit? In your myocardium. Okay, and if this mutated transthyretin deposits in your myocardium as amyloid, right? Obviously, we're going to have a thickened myocardium. So we're going to have a thickened myocardium, right? Because of the amyloid depositing in your myocardium. It's going to thicken the myocardium. And as we know, a thick myocardium can lead to restrictive, right? Let's fix this. Restrictive cardiomyopathy. Okay. And so so restrictive cardiomyopathy is heart failure with a preserved ejection fraction, which is what you would see if you did a echocardiogram. So if you did an echo, right, and if you're confirming a restrictive cardiomyopathy, what you would see is, of course, your left ventricular wall would be thick, and you would have diastolic dysfunction. But the main thing you would see is heart failure with a preserved ejection fraction. So your ejection fraction is normal, but you have heart failure. Okay. And so that's a echocardiogram finding for restrictive cardiomyopathy. But something else that's important in familial amyloid cardiomyopathy is that not only will the amyloid deposit in your myocardium, something that's different, right, from um, something that's different when you compare it to senile cardiac amyloidosis is that in familial amyloid cardiomyopathy, the amyloid fibrils can actually deposit on your nerves, on your peripheral nerves, leading to neuropathy. Okay, so let's go and write that down. So, well, first let's finish this. So again, if you do an echo, you're going to see heart failure with a preserved ejection fraction with left ventricular wall thickening. Okay, so you're going to see diastolic dysfunction. Because remember, restrictive cardiomyopathy is diastolic heart failure, but if you compare that to dilated cardiomyopathy, that's a systolic heart failure. Okay. So, but then what we said was not only does this mutated transthyretin misfold and deposit as amyloid in the myocardium, causing restrictive cardiomyopathy, this mutated transthyretin can misfold and deposit as amyloid on your peripheral nerves, leading to axonal degeneration and dysfunction of your peripheral nerves. So, how would that present, right? So, obviously, if we have a nerve here, right? So, let's say we have our dendrites and then our nerve and a nerve terminal, right? Then what would happen is, let's say In yellow, we represent the mutated transthyretin that misfolds and deposits as amyloid fibrils, right? So let's say we have all these amyloid fibrils depositing on the axon, right? This can lead to the degeneration of this axon and demyelination. So, that means that this nerve won't be able to do its job properly. Okay. So if the nerves can't do its job properly, what things would we see? Well, if let's say when when you get up, right, when you get up quick, right, or stand up quick, what happens is naturally your blood pressure drops, right? So in order to compensate for that, you would have to stimulate your sympathetic nervous system, and one of the outcomes of that would be to clamp down your blood vessels so you can increase your systemic vascular resistance. Okay. So naturally, when you stand up, okay, let's represent that with let's just say stand up. Okay, when you stand up, right, naturally your blood pressure will drop. Okay. But to compensate for that, what your body does is it stimulates your sympathetic nervous system and tries to increase your heart rate, okay, and also tries to increase your systemic vascular resistance by clamping down your blood vessels. Okay, so if your blood vessels are like this, your sympathetic nervous system will try to clamp it down so that you can increase your systemic vascular resistance and therefore increase your blood pressure back up to normal. But if you have dysfunctional nerves, right? Dysfunctional nerves, you can't cause vasoconstriction, because usually you would have your peripheral autonomic nerves, as we know from the nervous system chapter, that would go and stimulate our blood vessels and cause the blood vessels to constrict, right? This would be our autonomic nerves, autonomic nerves. But if you have familial amyloid cardiomyopathy, right, in which you have not only you have amyloid depositing in your myocardium, you also have amyloid depositing on your axons and your peripheral nerves. This nerve will have amyloid fibrils, right? And that will lead to the degeneration of this nerve, and it won't work properly. So you won't be able to clamp down your blood vessels and increase your systemic vascular resistance. So if you get up really fast and your blood pressure drops, your body won't be able to increase that blood pressure back up because you can't clamp down your blood vessels. So that's called orthostatic hypotension. Okay, so that's one finding that you would see in familial amyloid cardiomyopathy. Okay, so you'd see orthostatic hypotension when your pressure falls when you stand up. Okay, another thing you would see, because again, it's affecting your nerves. So, of course, you have nerves that supply your stomach. And one of those nerves, it's actually a really important nerve, it's a cranial nerve actually, is the vagus nerve, right? So if we look at the stomach here, right? Obviously, I'm not a good artist. So we have our esophagus here, and then you have your lower esophageal sphincter, and then this will lead to your stomach, of course, right? And then your stomach empties into your duodenum, right? So let's say that that's our stomach here, even though that's a horrible drawing. But so let's say that's your stomach, and what's important, what we should know is, right, your vagus nerve. So I'm just going to draw the vagus nerve here. Let's say this is your vagus nerve supplying your stomach. We know that the vagus nerve stimulates um, hydrochloric acid production, right? So it stimulates, let's say this is your vagus nerve first. Let's label this. And we know it stimulates hydrochloric acid production because it releases acetylcholine, right? And it also stimulates gastric emptying, right? So if there's food in here in your stomach, right? Like there's a bunch of food here, a bunch of chyme, right? It's going to The vagus nerve helps increase peristalsis because we know it stimulates your myenteric plexus. So it increases peristalsis and gastric emptying. So the vagus nerve helps promote right? Gastric emptying and peristalsis and digestion. Now, if this nerve has amyloid fibrils all over it, right, due to our familial amyloid cardiomyopathy, our mutated transthyretin amyloid fibrils, then obviously the vagus nerve won't work properly and it won't be able to release much acetylcholine onto the stomach, right? And that would mean you would have less gastric emptying. So this would lead to decreased gastric emptying. Actually, we said the down arrow. So decreased gastric emptying, and it would lead to decreased peristalsis and overall digestion in the stomach. So so delayed gastric emptying is actually called gastroparesis. Okay. So that's another finding due to damage of your axons and your overall, or damage of your axons and nerves due to the mutated transthyretin deposits as amyloid. Okay, so you have delayed gastric emptying, which is gastroparesis. Why is that? What will that lead to? How do you know you have gastroparesis? What are the symptoms of delayed gastric emptying? Well, of course, if you're not emptying the food from your stomach to duodenum or your duodenum, you're going to feel full pretty quick, right? Because there's still food sitting in your stomach for a longer amount of time. So you're going to have early satiety. So that's one finding of gastroparesis. And also, of course, if there's a bunch of, food and chyme and always in your stomach and it's not able to empty, that can lead to nausea and vomiting, right? And also like common digestive issue symptoms like bloating or abdominal discomfort. But another important finding for gastroparesis is postprandial fullness. Postprandial means after eating, and fullness, of course, means you're feeling full because you just ate food. But the thing is, you can't empty your stomach due to the degeneration of your vagus nerve fibers, which means you're going to feel full for a longer period of time, even after eating a small meal. Okay, so postprandial fullness. By the way, you can also see gastroparesis in patients with diabetes, because diabetes is also can damage your peripheral nerves. Okay, so those are the findings for gastroparesis, and those are actually the main findings for familial amyloid cardiomyopathy overall. So if you see restrictive cardiomyopathy, right? Cardiomyopathy plus you see orthostatic hypotension, as we talked about, right? Orthostatic hypertension, and you see gastroparesis, right? Those findings, gastroparesis, those findings are really important to keep in your mind, right? Because if you see these three findings, then you should also think about familial amyloid cardiomyopathy. Okay, so you should think about familial amyloid cardiomyopathy. Okay. And then so those are those are the important findings that I wanted to discuss for familial amyloid cardiomyopathy. I hope that made a little bit of sense. I hope this helped even a little bit. Thanks for watching, and I hope to see you guys in my future videos.